We're super excited to be here today, chatting about important health policies in 2024. We'll be covering a few proposed pieces of legislation, their intended impact, their status in Congress, and what primary care practices can expect in navigating these legislative changes. For anyone who's new to Elation Health, our story started in 2010 with a simple, modest vision to build an EHR designed to support the way physicians deliver primary care. The cumbersome legacy billing first EHRs, launched 2 decades earlier in the 90s, introduced inefficiency, cost, and heavy documentation burden. Elation's founders, Keena and Kanan, knew there had to be a better way. And so they joined forces and leveraged Keena's computer science and economics expertise with Kanan's health finance and management expertise to build the first clinically focused EHR, purpose-built for primary care. It was designed around their father's family medicine practice with a personalized, relationship-focused style of caring for patients. A clinical-first philosophy is the radical idea that technology can provide physicians with the freedom to focus on their patients. It's technology designed to support rather than disrupt the delivery of care. Now today, almost 15 years later, Elation serves over 32,000 clinical users across all 50 states, caring for over 15 million patients with the leading technology platform for high-value primary care. Okay, let's introduce today's speakers who we are honored to have with us today. Dr. Pastoor is a clinically active family physician and currently serves as head of primary care advancement at Elation Health, where she advocates for primary care and its powerful role in the healthcare system. Dr. Pastoor is a seasoned physician executive with 26 years of experience in primary care. She is a fellow of the American Academy of Family Physicians and spent the first 15 years of her career in the Army Medical Department. She has also led patient-centered transformation and primary care expansion in the academic and employer-sponsored primary care settings. Next, we have Penny Morris. She is the Regulatory and Compliance Manager for Elation Health, where she has been for nearly 2 years. Penny holds her master's in public health and has over 15 years of experience in policy analysis and building programs to meet policy changes. Her time has been specialized over the past decade in technical requirements, healthcare policy and value-based care, specifically MIPS and ACOs, and interoperability regulations. Penny currently leads Elation CERT efforts, MIPS support for providers, and all things regulatory. And we are very fortunate to be joined today by Jay Keese. Jay is the CEO of Capital Advocates, a prominent government relations and health policy firm based in Washington, D.C. With over 30 years of experience in health policy, Jay has a deep background in physician advocacy, having served as an aide to Senator John Hines and as part of the government relations team at the American Medical Association in the 90s. He is a recognized expert in the field, having authored key provisions in the Affordable Care Act related to advanced primary care models, direct primary care, and the 21st Century Cures Act's rules on the interoperability of health IT. Jay's client portfolio includes physician and patient advocacy groups, health IT developers, pharmaceutical companies, and state agencies. He is the driving force behind successful advocacy coalitions, such as the Direct Primary Care Coalition and the Partnership to Fight Chronic Disease. With extensive experience at both the state and federal levels, Jay has successfully passed legislation in over 33 states, helping to define medical care outside of the traditional insurance regulations. Currently, he is advising a coalition of large OBGYN groups on legislation to protect physicians who provide evidence-based care to women from criminal sanctions. These experts will provide valuable insights into the legislative landscape affecting primary care and share strategies to help your practice adapt and thrive. Now, let me briefly go over today's agenda. First, we will address annual regulatory updates focusing on CMS and ONC policies. Next, we'll discuss 3 initiatives designed to fundamentally change the way patients access care. Then we'll cover 3 initiatives designed to fundamentally change the way we pay for primary care. And finally, we will share insights into technology regulations and what they mean for providers. Additionally, for audience engagement, we have a few polls that we'll be conducting throughout the webinar about your practice and to better understand your reaction to these policies and regulations. Your participation is greatly appreciated. So let's dive in and learn together how we can navigate the complexities of health policies in 2024. Penny, the floor is yours.
Great, thanks Justin. Thanks for the introduction, walking us through the beginning here. We're going to jump into our 2024 federal policy updates. And before we get into too much content, we are going to ask a poll question and get a feel for who's with us today so we can better understand where to dive into different content areas. On our next slide here, we have our first poll question. If you can go to the next slide, please, Justin. Awesome. My practice is paid in the following payment models. Please select all that apply. So again, we'd like to get a better understanding of who we have today because it is a complex system out there, and we can better speak to some of our slides here today and see where you're at. Give you a minute to answer that, and then we'll go over the responses. Great. It looks like we have closed that. So looking at some of the responses, the majority of folks on the line today are participating in fee-for-service, only a little bit in MIPS, none that have identified as MSSP ACO or alternative payment models, and a few in direct primary care membership models. And it looks like a little bit that aren't sure. This does also reflect what we're familiar with on our side when we talk to providers. It's a pretty complicated system out there, and not everybody is aware of which contracts they're participating in. So again, this helps us kind of better refine what we're going to talk through today. Great, so let's dig into our annual regulatory updates. I'm going to walk through ONC policies and then CMS policies for 2024 and 2025, and what that might look like for folks that are on the line, for providers and practices, things to be thoughtful of and aware of that you should maybe think about. Okay, we'll start with our ONC policies. And this is also most familiarly known as the Certified EHR Technology Program, CERT program. At Elation Health, we are fully certified EHR technology, so we participate in these regulatory updates. Previously, they have been conducted fairly ad hoc. You might be familiar with 2015 CERT. And why was that still called 2015 CERT when we're in 2024? So that has just been updated. Those updates were coming not regularly, and the ONC is working to move that to an annual cadence to better align with CMS policies and other statutes so that folks can understand what's coming in the pipeline at the same time. Some of the reasons why these policies are important for providers and practices to know is this has a pretty large impact on EHR technology. So these are standards that we're required to meet, that we certify to. We may go through pretty complex testing. We might be required to provide extensive public documentation. And so as we get questions from providers and practices, or as folks are looking at their EHRs, these are important things that the ONC and CMS has set up to be publicly available so that the healthcare system can understand what their technology is bringing to the table. So starting at the top here, we've had really two big impactful regulations over the last couple of years, the Health Data Technology and Interoperability rules. There's just a proposed rule, and there was a previously finalized rule just in this year. What these rules are covering, starting at the top again, is US Core Data for Interoperability standards. So what these standards are essentially our data elements within our platforms. So if you're familiar with these or you're wondering sometimes, well, how come this data doesn't show up this way or it doesn't look this way? These are intended to standardize data across EHR platforms. And the intention here is so that our EHRs can talk to each other, so that when we're exchanging data with another platform, we know what to expect and how to expect that to some degree. Some of the challenges here is that EHRs have been operating for so long without these standards that these updates are going to take a little while to really be consistent across the EHR landscape. And there's also room for interpretation. So sometimes one data element may not match the exact data element at another EHR technology company. And those are things to be thoughtful of as providers, practices, when you're trying to understand that longitudinal patient data that might be coming in from a multitude of places. So we've got those US core data standards, those data elements that we're all going to be responsible for. Those are being updated. So the ONC that oversees certification, they're requiring all of our EHRs to update those standards to have additional data elements available. So that's a large undertaking. All of that data then has to populate in what's called the FHIR API endpoints. So this is an interoperability solution that is meant to really, again, standardize data exchange in the EHR ecosystem so that you can have confidence in the integrations and the platforms you're using across those standards. Moving on, a hot topic that we've talked about that Dr. Pastoor has been really a great advocate for is making sure that everybody understands the artificial intelligence or AI certification requirements. So these are important to note that EHR technologies that are certified are required to meet these standards. What that is providing transparency into some of the evaluation methods that we are using for our large language models, so that providers and practices can really feel confident and understand that these are safe and effective methods. And that, again, is consistent across technology, the certification landscape. Enhanced privacy controls are also included in some of these updates. And these are meant to really just align some of the standards. We're seeing increased privacy standards across states and HIPAA requirements. So some of you may have noticed some of those updates to HIPAA requirements, and EHRs are required to update privacy standards as well to make sure that that's consistent. TEFCA and data exchange standards, so the Trusted Exchange Framework and Common Agreement, is really exciting, and that has also continued to evolve with these new policies. These are not currently making every technology participate in them, but really having a framework to have consistent exchange. So how and when and what data are being exchanged are included in these policy standards. That way we can have more consistency across those data exchanges. So really wanted to set the tone here with our certification standards. And this is important for providers and practices, again, to understand as you're looking at different EHRs or understanding the capabilities and functions across technology platforms. We're going to move on to some of the intersections and overlaps now for providers and practices. So our quality collection types, these are a certain standardized function or feature of those certification standards as well. Electronic clinical quality measures we see are, we are certified to certain ECQMs. Then there's CQMs, just clinical quality measures, and claims-based measures. So y'all might be familiar with these when it comes to your reporting standards or reporting mechanisms. And we're required to meet certain standards through our certification to offer these metrics to you. And that way, everyone, including the receiving organization, generally CMS, sometimes HEDIS overlaps with these as well, have consistency in what data they're receiving, and they know that it meets a certain standard. So this way, it's not up to every individual to interpret what those measures look like, but it is consistent and everyone knows what is going into that measure. So I just wanted to touch on this as we segue into our MIPS and MSSP updates on our next slide here. So I did include all of these acronyms because if you think about how long it would take to write out each of them, it would be the whole slide. Starting at the top, we've got our Notice of Proposed Rulemaking in 2025. This is an annual cadence, so this does follow kind of a regular schedule, so it's exciting to see. Our Physician Fee Schedule, or PFS, for the Merit-Based Incentive Payment System, and Medicare Shared Savings Program Alternative Payment Models, or ACOs, MSSP ACOs. Now, I did see there weren't any folks that identified as participating in ACOs on the line, so I won't spend too much time there, and not many folks in MIPS. Hopefully you may be familiar with these, and or I saw some of the folks that are in direct primary care. Maybe you're familiar with these, and that's why you've moved into direct primary care. So some of these policies can be pretty significant and a lot of work. And again, that last slide where I was talking through those quality metrics, that's the mechanism that we're providing as that trusted EHR technology partner to provide practices and providers to then share with their reporting mechanisms. Some of the background on MIPS and APMs, if you're familiar with this has been phased in year over year, and we're getting closer to that fully phased in period. So a lot of what we hear is this is getting harder. A lot of the thresholds and metrics are increasing, and those performance thresholds has stayed consistent at 75%. CMS has aligned that that's a pretty good metric right now for them. It's not pushing too many people into negative adjustments and trying to keep the budget neutral program consistent with its intention. But if you've been following along or participating in this program, you may understand that it's gotten consistently more difficult with more measures, harder scoring over time, and we do see that continuing with the 2025 proposed rulemaking. What that looks like in the MSSP side, there were new ECQMs that were released for required reporting just in 2025, which is pretty quick to be introducing something that would be finalized right before the performance year. So I think what I've seen is that was a little bit surprising, but a lot of those measures have been consistent over time. So we've seen those measures on web interface reporting. We've seen them consistent in traditional MIPS and MIPS value pathways. And some of those measures are hopefully very familiar with you if you're participating in those programs. With the updated MIPS, there's that continued transition to the MIPS value pathways and APM scoring. And what that looks like is really just those bundles of MIPS value pathways. So some additional specialties have been added into the MVP bundles, bundles of measures that you can choose to report on. And the intention is to, again, include more folks. So as CMS continues to push providers and practices into MIPS and MSSP programs, they're continuing to have more options to participate in that regard. That aligns with that CMS goal of 100% of patients managed in value-based payment contracts by 2030. So they're really trying to move towards that space. And then finally, I'm just going to cover this quickly since there weren't too many folks on these programs. The physician fee schedule, so some advanced primary care management coding. That was really a big update to CCM billing. There was a request for information on how some of that billing would impact providers. So that's an opportunity if folks have reviewed that to look at that and weigh in there. As well as there was an RFI in the proposed rule to align HEDIS or private payer measures to other ECQMs. So CMS did acknowledge some of that hardship of having just a really broad landscape of reporting and trying to get everyone into some consistent reporting mechanism. So those were some exciting updates and highlights. Again, trying to keep it high level. We will move into some legislative updates. And before we do have one more poll question here just to see how that might impact folks. So on our poll question, which of these policy updates would impact your practice the most? Just out of curiosity. And it looks like there might not be too many, considering there weren't a ton of folks participating across different payment systems. But curious to get that participation here.
Penny, while we're waiting for the poll results to come in, I thought it would be helpful to just go over a little bit of background. Like I think one of the questions that people might have is, why do we have to do all this stuff? And part of the answer is there's been a continuum of laws that have been passed. And you mentioned, I believe you mentioned the sort of core of a lot of this was the 21st Century Cures Act. And even predating that, the 2008 Act that established the Meaningful Use Program that allowed for a large-scale adoption. And you know, it was assumed in all of these that we were going to move into a regime where, you know, like people are going to need to use a certified electronic health record to track this information over time. The Cures Act actually was just last year, so it passed in 2016, just last year put into place a lot of these requirements, such as USCDI and TEFCA, again, over a long period of time. And they were really designed to ensure that we're measuring apples and apples and not apples and pomegranates. And so making sure everybody's on a standard set of measures is really important. But it gives you a sense of how long some of these things take. And, you know, I think when you look at this, it's very important to understand that even if you're in a fee-for-service program and you're not doing a lot of these MIPS measures or APM measures, that with this goal being set by CMS, and it's a goal that's agreed on in a bipartisan sense, within 5 years, this is the future. So a lot of this regulation is being fine-tuned. It's actually becoming a little bit less burdensome as it's gone down through the continuum. And we're going to talk a little bit about some of the policy changes that have led to that. But I just thought that would be sort of helpful background as to where we came from and how long it's been, you know, sort of in the run-up to extend to promulgate some of these rules.
Yeah, thanks, Jay. I think really good context and additional. You're great at connecting the dots. So I think that is really helpful. I do see, so it looks like we've got some responses here. A lot of folks don't know, so we are glad that you're here with us today. So hopefully you're learning more, and this gives you some ideas of what is exciting or what to pay attention to in the policy worlds. And a good majority interested in the advanced primary care billing, so also very helpful. And additional standardized functionality from my EHR. So some things to think about that is that includes like what is required, what's not required. There's still a lot of space that's not required in that EHR functionality. To Jay's point, further aligning things in certification and across these regulations takes a pretty long time, which is what we're going to talk more about today. So with that, I'm going to hand off the mic.
Thank you, Penny. And just to add on to what you and Jay were both talking about, we don't typically, you know, as a physician, until I worked for a tech company, didn't really understand what CERT meant or why that would be important when I'm trying to choose an EHR for my own practice. And, you know, what I've learned is that even if you're not involved in MIPS or MSSP or any of those alternative payment model mechanisms, if it's just fee for service or if you're in a membership model, you still want an EHR that is certified for no other reason than for the interoperability. Because if your EHR is not certified, then there is no expectation that you are creating data that meets those standards and that is common across EHR platforms so that we could share data about our patients as our patients move through the health system. So I just wanted to touch on that real quickly.
Hey, and Sarah, and I can add in there one more thing about that that's really critically important. Part of that 21st Century Cures Act that established these, that actually was just promulgated last year, was that there are there's the ability for HHS to levy $1 million per instance fine for any technology platform, provider, hospital system, whatever, that blocks the seamless flow of health information. So if you are interacting, even if you aren't a CMS fee-for-service or MIPS or ACO, if you're interacting with somebody that does, and you're sharing inoperable information across the continuum, there's some risk on your part if it's not going through a certified EHR like Elation, because they're not going to pass information like that. So it's really, really critical, even if you don't understand all this gobbledygook, candidly.
Yeah, for sure. That's a great call out. Thank you, Jay. So moving on now to some other legislative updates that are less tech focused. There are several bills that have been introduced which could really meaningfully impact both how patients access primary care and how we pay for primary care. And as we all know, access and payment mechanisms are key areas for improvement in our healthcare system. So let's get into it. Next slide. The first bill I want to talk about today is called the Primary Care and Virtual Care Affordability Act. So this bill would do two things. The first thing is it would extend pandemic telehealth coverage for another 2 years. And then the second thing is that it would make primary care services a covered benefit pre-deductible in high deductible plans without an HSA and covered under the HSA for plans with one. So this act really is crucial to ensure both flexible access to primary care via telehealth, which is essential for patients who maybe can't access care locally due to transportation concerns, or maybe they don't have local PCPs. And then it would also ensure access to primary care for commercially covered patients with financial barriers. The second bill is the Chronic Care Management Improvement Act. And this bill applies to chronic care management services and billing, also known as CCM. And this would remove the patient cost sharing aspect from CCM, which would really be an important step towards removing that financial barrier that prevents patients from accessing care management services, which we know are so key to preventing complications from chronic disease. And then the third bill is the Improving Care for Youth Act. And this bill would eliminate the nonsense antiquated reimbursement restrictions when both primary care and behavioral health services are delivered on the same day. And this is for children in Medicaid and CHIP programs. Medicaid and CHIP cover more than 80 million Americans, including a disproportionate percentage of rural citizens, people with disabilities, and people of color. So this would help expand access to mental health services for youth by removing that barrier of billing restrictions and supporting better handoffs in team-based care. So now I'll pause here, leave the slide up please, and I'll ask Jay to chime in with any of his insights about these three bills.
Yeah, thanks, Sarah. And this is a great selection of things that could move this year. Let's take a look at them. So the extension of the COVID era telehealth exceptions, and in this bill in particular, those that would involve payment for certain services under telehealth that were previously only allowed under regular office visits. But it would also allow for the use of telehealth services with individuals that have HSA qualified high deductible plans. And why is that important? Well, simply because, as you probably know, we should have another poll on here. How many people on this call have an HSA high deductible plan? These plans are designed very differently in statute than some others. Because with an HSA that looks at tax qualified pre-tax expense dollars that are put into an account, it's not only the HHS, it's the IRS that has a lot of regulations about what qualifies you as an individual to put money into that account. So if you have a high deductible, if you have an HSA, it has to be paired with a high deductible health plan, and it can't have a second health plan or coverage of any sort, including a telehealth benefit that might offer things that are already offered in the high deductible health plan, like primary care. So in the next series of slides, we're going to look at an issue that's very similar with direct primary care agreements that get in the way of these plans. So this would essentially for 2 years extend that policy as well. So we're looking at a complicated web of laws that govern, not only HHS and the kinds of things that we're talking about with all the measures, the ability to provide telehealth services, and now the tax code as well. So it's a fairly complex piece of legislation. I will say that in this crazy election year where we all have political whiplash, not exactly sure what's going to happen in a couple of weeks and who's going to be in charge, one of the things I think you can take to the bank is that we're going to have a year-end healthcare package that will extend certain policies in CMS, in HHS that need to be extended beyond the end of the calendar year. And this idea of extending the COVID era telehealth benefits is driving the train. So everything else that might move is really being driven by this bill. So we do expect some version of this bill to pass. If I were a betting man, I would say that it extends for 1 year and not 2, simply because that adds to the cost of the package. And we're going to also be doing this in conjunction with some sort of a budget resolution to pass the budget for fiscal year 2025, which, by the way, starts at the end of September 2024, but we're not going to meet that deadline. So we'll all be back here looking at this. So the other 2 bills, could ride on that first bill that extends the telehealth incentives, HR 7671. It also extends certain disaster relief provisions. So they're basically dumping all of these things that they need to move at the end of the year into a bill like this. I think a number of these other things we're going to talk about would as well. Briefly on the Chronic Care Management Act, this would extend and expand the kinds of things that you can do as a part of the chronic care, the CCM codes, the chronic care management codes. And I think there's a great debate about the way those codes should be used. And as we move into 2030, when we're moving into an environment where everybody in Medicare is a part of an APM, and there's really no longer any plain old fee-for-service out there, these codes provide an opportunity for practices to candidly make a whole lot more money and coordinate care a lot better. I'm not sure that it shouldn't be reversed. Maybe we ought to be coordinating care better and then making a little bit more money. But as all of this, it's always about in politics, follow the money, right? So these payment reforms really are driving behaviors that are really, really critically important. And the extension of the youth behavioral health exemptions also made earlier as a part of COVID could very well likely maybe a part of this. So while these bills might not move separately in their own votes and have a big press conference afterwards to say, hey, we just passed the telehealth exceptions, or we just passed better behavioral health care for our youth, they will all likely be in one large package that's coming together. And we'll talk a little bit about some payment reform issues that might be bundled up into that, just so tactically you understand that these things might not move separately, but they're more than likely going to be part of a package that extends the telehealth. And if you turn on, CNN the day after this passes, that might be the only thing you hear about. But it will have a number of other things that are likely to impact your practices.
Super helpful. Thank you, Jay. All right, let's move on to the next slide, please. Okay, so our 4th bill is called the Primary Care Enhancement Act. And this bill proposes a change to the IRS code, which would allow a medical expense tax deduction for direct primary care membership fees. This is what Jay was just referencing a moment ago. So it would provide that participation in direct primary care or DPC memberships can be paid out of health savings accounts. And this code would help make direct primary care more flexible and affordable for all Americans covered by an employer health plan with an HSA or a commercial plan with an HSA. The next one, number 5, is the Medicaid Primary Care Enhancement Act. And I'm delighted to report that this bill has been passed by the House and has now moved to the Senate. So this groundbreaking legislation would clear the way for states to work with CMS to provide Medicaid beneficiaries access to direct primary care, or DPC. And this is pretty widely supported by the DPC community and would allow them to embrace an underserved high-need patient population and let them provide them access to really high-value patient-centered care at a reasonable cost via prepaid membership fees. The final bill we'll cover today is the Pay PCPs Act. This newly introduced legislation would task CMS with reforming primary care payments for Medicare beneficiaries by establishing a hybrid payment model. So the act introduces a combination of prospective or per member per month payments and traditional fee-for-service payments. The change is intended to provide more predictable and flexible revenues for primary care practices and would enable them to offer comprehensive and continuous care, particularly to those with chronic conditions and complex needs, while removing the toxic incentives of pure fee-for-service. So I'll pause again here for Jay to provide his insights on the status of these policy proposals.
Well, thanks again, Sarah, for covering these in particular. And as you mentioned, we had our hands in writing both S628 and HR 3836, and we're super excited that the Medicaid Primary Care Enhancement Act has passed the full House of Representatives. We are certainly hopeful that this will travel on that year-end package that we're talking about, or perhaps even be hotlined in the Senate, which means that the Senate could take it up in an up or down vote. So it is a great idea. So I think a key question that might come to mind is, like, how are these all related? So one bill would make HSA high deductible plans compatible with direct primary care, the way the other bill we talked about made them compatible with telehealth. The other bill would bring direct primary care into Medicaid, and the other bill would somehow invent some sort of new hybrid payment model for Medicare. The Congress for the last 6 to 8 months, and maybe even longer than that, has really been taking a deep dive into the future of APMs, for the future of CMS, the Medicare CMS Innovation Center, which was established by the Affordable Care Act to sort of test out these new models. Interestingly enough, direct primary care, we also got a provision in the Affordable Care Act that calls out direct primary care as an advanced payment model that is essentially a primary care service not regulated by state insurance commissioners. So, there's a lot going on in all these. What it's saying is that there's a bipartisan will in Congress to move into payment models that are simpler, easier, require less measurement, and really, I think, fundamentally are going to move towards a direction of a monthly fee payment for primary care services. Now, the Pay PCPs Act was established by Senators Bill Cassidy, a Republican from Louisiana, who's a doctor, a gastroenterologist, and Sheldon Whitehouse, who's very active on the APM front. Rhode Island is a state that has a ton of, there's probably more advanced primary care models in Rhode Island than maybe any other state per capita. So they're really anxious to move this along. And this came as a result of a couple of hearings the Senate Finance Committee held this year, where the committee chair, Ron Wyden from Oregon, Mike Crapo from Idaho, the Republican ranking member, kind of looked at each other and said, hey, shouldn't we really be moving Medicare for primary care, which we know is important? We want to pay for it up front. We want to pay for it in a much simpler model. We want to reduce some of the burdens that you all have to report using MIPS and some of these, quality measures of the Medicare shared savings programs, which at some point required primary care physicians to report up to 33 different quality measures of things that they might not even know about, candidly. So, a lot of people have sort of wrung their hands about this and said, hey, I don't want to do any of this stuff. It's just too complicated. So there is a real move in Congress to try to simplify, move to a unified monthly payment structure for primary care, and perhaps move into a single billing code for Medicare that says all of those primary care CPT codes and the E&M codes are going to be, you can do your fee for service and do all your reporting and your MIPS over here, or you can take whatever the number is, and the devil will be in the details. How much is it? Is it 70, 80, 110 bucks PMPM? and just take the flat fee and do all the primary care. And then the reporting module, again, a really important reason to have really good data transfer through an EHR like Elation. The reporting structure would then be not the primary care practices themselves reporting, but Medicare reporting downstream data of how are these patients doing when they get out of primary care. Are there more patients being referred to the hospital? Are more patients being going into advanced specialty care and surgeries? Or are we fixing more of the problems in the primary care setting? And that's what all of this, again, follow the money. If we give a high enough upfront payment to primary care physicians, we value primary care where it should be valued, we should be able to do more. Of course, it's important that doctors, and other practitioners in primary care have the opportunity to spend the amount of time they need to spend with their patients to do this diagnosis and treatment in that primary care setting. So I think we're seeing the start of things. It would surprise me to see any of this Medicare payment reform move this year because it's very complicated and there's an awful lot of players at the table. But I do think we're in an era now where we're looking at moving to a simpler, more flat fee structure for primary care, and there's a lot of bipartisan agreement on it. So we're going to be watching this really closely. Again, it would surprise me to see that the final bill here, the 4338, would be a part of the year-end package, but we're certainly hopeful that the two DPC pieces, which have been around for a number of years, would be a part of that package, and we're working really hard to move that forward with an awful lot of other reforms that would, again, simplify and streamline the payment process for primary care, making it easier for clinicians to do their jobs rather than spending a ton of time billing and coding.
Always love those analyses. You do such a great job with that. Thank you so much for those insights, Jay. I think if we move on to the next slide, you wanted to reference these.
Oh yeah, we really just sort of put this on here for folks that are interested in the two bills that are moving. Again, the Medicaid Primary Care Improvement Act and the Primary Care Enhancement Act. These are one-pagers. You'll have these to download, but it sort of explains the mechanism of action in these bills. The Medicaid bill in particular is pretty interesting because there was a program a while back in CMS called Money Follows the Patient. And the idea was we're going to send these payments into rural and urban underserved areas. The money wasn't necessarily going to go to any one provider, but it was going to go for the patient, to the providers that the patient is using. And I think the DPC example is pretty similar to that. Money might flow through the Medicaid program to perhaps an FQHC, where instead of just going to the FQHC to get care from a random provider, it's allowed to go to a Medicaid patient, so the Medicaid patient could choose a primary care doctor that they have their cell phone and can call anytime they want and have a personal relationship with. So that's one in particular that we're excited about. It's going to require a lot of sort of interaction between the physicians that are practicing in the DPC model in these states, between CMS, that's going to be able to set the rules for how the money flows out, and the states that set the rules for how the money flows in and then out to the doctor. But we think it's a good idea. It's got support of everybody from Earl Blumenauer and Kim Schreier, who are on sort of the left side of the Democratic caucus, to the right side, guys like Bill Cassidy we talked about, and even people like Rand Paul and others have supported these ideas that are really designed to sort of simplify and democratize primary care. And so, let's keep our fingers crossed. We're working really hard. We're going to have a fly-in in DC. You can go to our website, dpcare.org, and find out more about that on September 10th. We're going to spend 2 days on Capitol Hill pushing these rocks up on Capitol Hill, trying to get them across the finish line before the end of the year this year. So happy to take any questions afterwards or welcome any feedback. But you'll have these one-pagers to look at, and these sort of describe in detail, exactly how these bills work.
Where can people go to get bigger versions of these one-pagers?
You can get them on dpcare.org, our website. But I think you'll find if you expand this slide into a PDF, it should read pretty good as a one-pager.
Okay, great. And we've got those resources on our wrap-up slide too, the URL for the website. All right, great. So I think we have one last poll question here. And the question is, which of these legislative changes, those 6 that we just reviewed, would help your practice the most? And you should select all that apply. And we didn't list all of them.
Yeah, we got some of the right ones.
Yeah. Okay, good. Pretty equally divided. Maybe a few more on the Primary Care Enhancement Act.
Yeah, I will say the HSA piece, candidly, both for telehealth and for direct primary care, doesn't make sense to a lot of people. This goes back to 2003 and the Medicare Modernization Act, which established the Part D program and set these rules up for how to contribute to HSAs before there was direct primary care, before there was telehealth, before there were really cell phones, and the technology that we interact with on a regular day. They just need to be updated. And the
Yeah.
problem is, every time you go to try to update these things, it takes revenue out of the treasury from the tax code. So they wind up scoring with these enormous scores, billions of dollars over 10 years to try to make these fixes. And we know that those numbers would be offset by improving care and reducing costs in the Medicare program in particular, or the Medicaid program, or in private pay programs. But you never get any credit for that score, so it makes these things really, really hard to do because they look really expensive going in, and they get pilloried as being expensive tax breaks for rich people and health plans. But the reality is they're really impeding our ability to grow these innovative primary care models.
Yeah, and then we have the issue of budget neutrality, I think, because the impact of
Yes.
primary care doesn't turn around in a year. It may take a while for that return on investment, so that's kind of frustrating too.
Yeah, you have to find a pay for any dollar you take out of the treasury, so it makes it really difficult. You've got to rob Peter to pay somebody's Paul.
Mm-hmm. Mm-hmm. All right, great. Well, let's move on to the wrap-up slide. I'll pass it back to Penny here.
Yeah, thanks, Sarah. Thanks, Jay. So we wanted to include this for the resources so that you all can also keep this with you when we send out those slides. Just a little bit of what we covered today. Covered a lot of content, a lot of material at a pretty high level, but hopefully it gave folks that are on the line some more tools, some better understanding, better footing for kind of what the landscape looks like now and what to look forward to in the future. Where are we going? Where are we at, and where are we going together? And anything to add here? Otherwise, we can move into our Q&A session. Great, then I'll hand it back over to Justin to help moderate through some questions.
Thanks, Penny. So I know we don't have a lot of time left, but we do have some questions that were submitted. So I'd like to get through a few of these if we can. And if we're unable to address anyone's questions, we will follow up with you after the webinar. Thank you again, speakers, for that great walkthrough of the key health policies impacting primary care. It's clear that staying on top of these changes is crucial to minimize practice disruptions and ensuring compliance. So we're going to open the floor to questions. Please feel free to type them into the control panel, and we'll follow up as we have time. While we wait for those to come in, let me remind everyone today's session is being recorded. The recording will be available for you to revisit or share with colleagues who couldn't attend, as well as the slides. Okay, let's dive into the questions. The first one here, presenters, I'll let you decide who answers what. When shopping for an EMR, what are the 3 questions I should ask to make sure the EMR is safe and compliant from a technology standpoint?
I can jump into that. So hopefully folks took away some more information on certification and some of the work that we do as an EHR technology through the certification program, Certified EHR Technology. Would hope that when you're looking through, different platforms or you're shopping around, you're trying to understand what's publicly available. So are they certified first? And that will really give you a better understanding of the overall technology and certification. And then digging into that, what certification components or what standards are really relevant to your practice or to your needs. So starting with your certification, you know that that platform is going to meet the baseline for certification. And then you can also find which ECQM measures might they be required or certified to, and what does that look like beyond the initial certification. So I would say that those would be kind of the key components to look for. Anything to add from Sarah or Jay?
Well, I would just say I think it's critically important that you use a certified EHR. I mean, again, you're putting yourself at some legal jeopardy if you're going to be exchanging data with anybody into the Medicare system, Medicaid, if you're not, and that's critically important. And then what I like about my experience with our clients who use Elation is that it's an understandable and great interface that's easy to use too. That's pretty important as well. And sometimes those things are really hard to accomplish together. You know, making it easy to use and making it able to follow all of these requirements for certification. So hats off to you guys.
It does take a lot of effort. I guess I'll throw in like kind of the, I don't know, dirty little secret that a lot of people don't know, which is that certification is largely the result of attestation, which means that we basically just have to attest that we did these things, and then we get the certification. But still, that protects the user from any kind of, legal fees or anything that might be attached to results that, a bad outcome to a patient because of failed interoperability or whatever.
Agreed.
All right.
Yeah.
Move on to the next question here quickly. If the Medicaid Primary Care Act passes, will there be coding requirements for participating DPC practices?
Wow, we sure hope not. So here's what we think would happen. So the answer is it's CMS. So the answer is probably yes. But how does this sound? Maybe there's one code, that is a universal code for a flat monthly fee for all the primary care for a single patient. I think that would be the bogey. And then our idea here would be on quality measures and the other things that you see in some of the MSSP programs and others would hopefully be measured by the Medicaid agency and CMS downstream by measuring hospitalizations and that sort of thing. That's our vision for this. But what the bill does, to be clear, is it sets up a dialogue between CMS and the states so that the states can figure out, exactly, exactly how to make this work. And it's going to be very different than in Idaho than it is in Texas than it is in Massachusetts. So, each state will have an opportunity to work with its local DPC environment to figure out what works best there. So we think it's a pretty flexible and neat idea that doesn't bind you to a set of codes automatically. But it's possible in Massachusetts they might want some reporting that they don't really care about in Texas too. So we don't really know the answer to the question fully, but the idea is to reduce that reporting burden as much as possible and just pay you a flat fee.
Okay, thank you, Jay. Next one, if the HSA Act passes, how will this impact growth of the DPC movement?
I guess that's me again. So right now, 29% of everybody that has a health plan has, and I think this is a really low number, but the 2024 numbers were that 29% of all health plans were HSA, high deductible plans. So imagine a world in which you started a business and 30% of the market was not able to hire you because of some regulatory problem that was written in 2013. This would get rid of that position. So there's really two things the bill does, as Sarah mentioned. Number one, it does say that you can take the money out of your HSA and pay your DPC doctor. But more importantly, what it says, and this is the same thing for the telehealth provision, more importantly, what it says is that if you have an HSA high deductible plan, there's nothing stopping you from having a contract with a DPC doctor. So that second piece is the really important part. And we're working with big employers like Amazon and Boeing to expand DPC into their lives. And nobody in those programs that has an HSA is allowed to participate in them. So, I mean, more and more, some of these large firms have only HSA high deductible plans. So we think it's a major growth opportunity for DPC, particularly among employers. I would say this policy impacts almost 100% the employer sponsored world, and then to some degree the private pay world, the individual people in the Obamacare exchanges or the individual side. But if you want to grow DPC in the employer space, this is key. It's pivotal.
Yeah, that's how I was going to frame it as well. Because employers more and more want to provide DPC as a benefit, but they want this to be the beneficiary's choice. And so if you have an HSA and you choose to go to DPC to get a PCP in a DPC model, then this is a way for the employer to cover that cost so that it doesn't have to come out of your paycheck. And right now, employers don't have that mechanism to deliver DPC or offer DPC to their employees. And so this would really open the door to a lot more opportunity for employers to offer that as a benefit to their beneficiaries, and therefore open the floodgates for folks to seek care in a DPC practice.
Yeah, it's by far and away our number one issue. We love the Medicaid idea and things we want to do in Medicare, but the thing that impacts our physicians the most is the HSA prohibition.
Do we have time for one more, Justin?
Yeah, thank you both. Let's squeeze in one more real quick. This question is from a new DPC startup with a hybrid model, so they can care for Medicaid, Medicare patients from FQCHD population. Question is, should Medicare billing follow along the value-based payment model, given that in 5 years it will be the way or fee-for-service approach? Looking for the simplest method to get started.
Sarah, you wanna try that one first?
So if I understand the question correctly, they are starting a practice that's both fee-for-service billing and membership. So it's hybrid. And they're trying to decide what kind of fee-for-service contracts to get into for Medicare patients and or Medicaid patients. Should it be more value-based contracts, or should it be more fee-for-service contracts? And my recommendation would be value-based contracts. Because I think that is definitely the direction that things are going. I think there's more revenue potential there, especially with MSSP. But if you're going to do that, I would do that as part of a network like Aledade or Astrana or one of those. That's my thinking. I don't know. What do you think, Jay?
So I would a word about MIPS, and it was interesting to see nobody's doing it, and that's exactly the way it was designed. I would say don't do MIPS. I mean, MIPS is designed to be a carrot to get you into the APM that Sarah was just talking about. I think it's smart to jump right into an APM. I think you'd find the revenue side on the APM is probably going to be a little bit higher if you're doing the things you need to do. It'll also give you an opportunity to do a little comparative analysis about, okay, this is how my patients that are in an APM that might be in a different TIN or EIN that are in the DPC practice, and do a little compare and contrast to, candidly market these two different approaches to your different patient populations. So, I mean, I think the APM thing is the way to go. And I'd maybe even take one step further and say, the risk-bearing models, the ACO REACH, that allow the practice to take a little bit more, have a little more skin in the game, and do a little bit more and be a little bit more flexible. There's even some room for DPC to play in some of those as well. So dig in as hard as you can. And I know the folks at Elation can help you make some of those decisions if you're on the platform too. So and we're happy to help advise in that space as well. So that would be my thinking, Sarah.
And I would just want to add one more thing on there that I think we hear a lot of feedback from our customers and just across the industries. Just making sure as you're looking at that you understand what the contracts are. So look at what those APM requirements are and what would you be required to submit, or what do you have to regularly bill for, and kind of compare those requirements across the contracts when you're looking at your ROI, because it might be that one gives you more money, but maybe your reporting requirements is a longer laundry list than you can really carry.
I would also just caution that if you're going to be seeing Medicare patients in a practice that is also doing membership separately, to not offer memberships for Medicare patients, because you can get into some trouble there. Yeah, I would stick to non-Medicare patients on the membership side.
And of course, none of this is legal advice because none of us are lawyers. But
Thank you for saying that. Yes.
before you do, before
Please
you do
consult a
any of this,
lawyer.
really consult your attorney that understands CMS regulations and that sort of thing. So
Yeah.
Good concluding thought there.
Yes,
Okay,
yeah, it really
Jennifer.
was. Yeah, excellent guidance. Wonderful, wonderful. So thank you all for your thoughtful questions and for participating so actively. It's clear that there's a lot of interest and understandably some concerns about navigating health policies in 2024. I hope that today's discussion and insights have provided you with valuable information and strategies to tackle these challenges head on. Before we wrap up, I'd like to extend a huge thank you to our speakers, Dr. Pastoor, Penny Morris, and Jay Keese, for sharing their expertise with us today. And of course, a big thank you to all of you for joining us. It's been a pleasure to host this session and connect with so many of you. Elation is here to support you every step of the way to streamline your operations, ensure compliance, and enhance your practice's financial health. We'll be sending out a follow-up email with a link to the recording of today's webinar, along with additional resources that you can use to help further explore the topics that we've discussed. And we also welcome your feedback on today's session, so please don't hesitate to let us know what you thought and what you'd like to see in future webinars. So thank you once again for spending part of your day with us, especially the extra few minutes that you've granted. Stay safe, take care. Goodbye, everyone, and we look forward to
Thank
seeing you at
you.
our next webinar.
thank you.
Thanks all.